And a little bit about our speaker, Dr. Bruno. Dr. Richard Bruno is a trained family and preventative physician and the Multnomah County Health Officer. Prior to serving in this position, he was the Senior Medical Director for Primary Care at Central City Concern, a wonderful Portland-based agency that serves the unhoused community. Dr. Bruno earned a BA in psychology from Princeton and graduated from OHSU School of Medicine. He has advocated for patients' health, both in the clinic and through public policies at different levels of government. Today, Dr. Bruno will explore factors that have contributed to trends in opioid-related deaths, from upstream prevention interventions to midstream harm reduction to downstream overdose reversals. And so I'll be to welcome you back there.
Thank you so much, Jonathan. So nice to be here with all of you, and thank you for coming on this beautiful Friday. It's really gorgeous out here, especially on campus. It's so nice to be down here with you all. So yes, I am really excited to talk with you about some of the trends we're seeing nationally, statewide, and locally in Multnomah County, which is the greater Portland metropolitan area. And before we get started, I just wanted to briefly let you know that I don't have any financial interest to disclose. And I always like to dedicate talks that I give on opioids to one of the patients that I lost. Mr. Theodore Williams died a few years ago, and he was somebody who was one of the first patients I ever took care of in residency. After I graduated from med school, I went out to residency in Baltimore, and I took care of Mr. Williams for a number of years while I lived out in Baltimore. And he really taught me a lot about the human side of addiction medicine and really what it takes to sort of work with people and try to get them the help that they need. And oftentimes the systems are not set up people up for success. And unfortunately, he succumbed to his disease and overdosed and died. But I worked with him for years trying to help him hold up the work that is not only happening in our local hospitals and clinics, but in the communities as well. And so in memory of Mr. Williams, we'll start our talk today. So some objectives, just want to kind of get you, we're going to do a quick run through of like kind of the opioid crisis in the US. And it's a very broad topic, and you probably have some knowledge about where things have headed and some of the recent advances in the opioid crisis field. But I also want to talk about some of those dangers that have happened to patients and communities. And then, as Jonathan mentioned, we'll be talking kind of upstream, midstream, and downstream approaches to preventing opioid deaths. So first of all, let's take a look at some of the problems. And here I want to show you there's kind of four main waves that we've really seen since about 2010. And that first wave really started to happen back in 2010, back in around 2000, when opioid manufacturers like Purdue Pharmaceuticals really were started to push opioids and the prescribing of opioids to the extent that they were ignoring the harms and really pushing on treating people's pain and treating the pain. And we're going to talk about kind of how that happened a little bit. What that led to was that more people started using opioids, getting addicted to opioids like oxycodone, hydrocodone, morphine. And then around the second wave, around 2010, as some abuse deterrent formulations started to come online, people turned to street heroin and illicit heroin so that they wouldn't get sick. And so we started to see a wave of folks, and you see this orange light here, heroin really started to pick up around 2010. Then what we started to see is this blue line of synthetic opioids really started taking off around 2014. And that third wave happened where fentanyl, illicitly available fentanyl, started to eclipse heroin on the streets. It was much more powerful and also much more addictive and much more deadly. And then recently, what we've started to see is fentanyl in combination with methamphetamines really driving a lot of these opioid overdose deaths. And we're still sort of in the middle of that fourth wave at the moment. Locally in Oregon, what we can see, these lines are the different years. And so you can kind of see each year we're sort of to get more and more opioid overdose deaths. And these across Oregon have really become a lot more concerning and raised a lot of red flags, about the work that we're doing to try and prevent these deaths. And what we can see is that we did have sort of late last year started to come down a little bit month by month, and started to the pink line started to come down a little less than the year before. And so we're starting to see a turnaround here. We're going to talk about kind of why that's happened. Here's another way to look at this data. We'll start with a sort of Multnomah County, Washington County, Clackamas County, tri-county metro area up here, which is around half the population of the state in these three counties here, and also about half of the overdose deaths happening in those three counties as well. And what we see sort of nationally is that the rate of overdose deaths have really increased from 21 to 22 by about 14%. In Oregon, it was a big jump. We really kind of hit late compared to the rest of the nation, just in terms of how fentanyl has distributed and the drug trafficking across different areas of the country. So Oregon kind of hit late, and then our tri-county area up here also had like a pretty late, but even more marked increase in overdose deaths that were that fentanyl meth combination there that I mentioned. Now, there's been some headway, and we're starting to see that things are starting to turn around a little bit. From April 23 to April 24 this past year, there's been a 10% decrease nationwide. And so all the blue states you're seeing are ones that have had a decrease in opioid overdose over that time period. The yellow states have still had either an increase or staying about the same. So you can kind of see that there's that distribution there. And we are a little bit sort of, as I said, late to the party here, because a lot of the overdose death decreases have happened in the eastern side of the country, and then kind of funneled over to the western side based on those drug trafficking patterns. But we're keeping a close eye on it. We're really working to make sure that we have a good eye on this. And we have this wonderful new dashboard that we just released a couple of months ago at the health department. It's our first public dashboard of any kind, but it's really one of these ways we're trying to get more transparency and accountability for the work that we're doing. And so there's a QR code up there if you wanted to check it out. And you can also go to that tiny.cc/fentanyl dashboard web address. And what you see here, and you can bring it up, there's 5 different data sources. So what we did is we actually worked with our local fire department, our 911, our police department, our hospitals, and our medical examiner's office at the health department to put together a database, a dashboard that had all of these data streams in one place. And that was really the first time we'd had any kind of interagency collaboration, which was an exciting new development as well. And what we started to see, this top row up here is 2023 month by month. And these are the confirmed or suspected overdose deaths in Multnomah County, specifically month by month. And so, and the average for last year was about 52. The average per month, the average for this month, or this year, what we started to see is starting in about March, we're really having a downward trend here across, a little bump in August. And we're really starting to see a much better trajectory here in terms of the damage that opioids are causing, especially fentanyl, are causing in the community where it relates to overdose deaths. So we're liking that trend, and we're going to talk about kind of why that's happened a little bit as well. But first, let's go and do a little bit of a retrospective here and talk about why we're in this mess in the first place. And so you may be familiar with the poppy plant that you can score and open and get, heroin is really derivative from that poppy plant. In 1806, morphine was isolated from the opium. And by 1843, the hypodermic needle was invented by Dr. Massey. And unfortunately, in a very tragic turn of events, his wife was the first opioid overdose victim. She used it and became and overdosed and died. A few years later, heroin was synthesized, initially intended to be a non-habit forming alternative to opium, but it was actually 10 times more potent. And then since then, we've had dozens of other kind of synthetic opioids and other molecules isolated, different formulations: codeine, fentanyl, hydrocodone, hydromorphone, oxycodone, OxyContin. And then another tragic turn of events, in 1961, the antidote was discovered. This was Jack Fishman And he isolated naloxone, which was a strong antagonist of the opioid receptors, and actually blocked those receptors. And unfortunately, his son died without the antidote. So it's just another sort of tragic piece in this story that's unfolded. Here's an example of an opiate epidemic in the Ming Dynasty. And so since then, we've really started to see more and more systematic problems that have allowed these medications to be dangerously available to people. In fact, an FDA reviewer named Curtis Wright, he kind of gave the rubber stamp to the OxyContin from Purdue. He actually had been working with them kind of behind the scenes, and he allowed the package insert to assert that the delayed absorption reduced abuse liability, which was not quite true. And then there was a lot of efforts among many organizations, including American Pain Society, the VA, the Joint Commission, to really push pain as the fifth vital sign. They encourage providers to really check pain, ask about pain. If people are in pain, treat their pain, treat their pain. So that was really kind of led to this kind of more increased prescriptions of opioids, especially OxyContin, oxycodone. And then there was this really interesting a New England Journal of Medicine. It was a letter to the editor. It wasn't a peer-reviewed journal article, but it was a description based on Porter and Jick. They were physicians in a hospital in Boston, and they were essentially asking people who had been discharged from the hospital on an opioid. They called them and asked, how are you doing? Do you feel like you're doing okay, or you feel still like are you having withdrawal symptoms or feeling addicted to this medicine? And they estimated, just based on that, it was a very small sample size, that it was less than 1% of those patients who actually were still addicted to an opioid. Unfortunately, this non-peer-reviewed study was used as kind of the poster child by pharmaceutical companies. They quoted it left and right. They said, according to Porter and Jick, less than 1% of people get addicted to opioids. We now know that it's much, much higher than that. And so they did pharmaceutical companies, especially Purdue, one of the most infamous ones, really started pushing on the prescribing. They did a lot of pharmaceutical detailing and clinics and hospitals where they talked about the benefits of a long-acting or delayed release OxyContin as a way for people to keep the pain under control without having to take a lot of pills throughout the day. Their sales and promotion really, really skyrocketed from the late 90s to early 2000s. You can see there, the number of prescriptions went from 300,000 to over 7 million over that time period. Their sales went from 44 million to $1.5 billion in that time period as well. And you can see year after year, a lot more prescribing, a lot more people getting addicted to these very addictive medicines. They would send these videos to doctors' offices, these VHS video cassettes, and they'd mail them to the offices, and you'd watch it, and it'd be like somebody saying, how I got my life back together. I'm free from pain now that I'm on OxyContin. And they'd have these marketing videos. They would try to, get doctors to prescribe more. Unfortunately, as we now know, that had a huge repercussion and caused a lot of more harm. And so actually, in 2007, the Purdue executives pleaded guilty in federal criminal charges that they misled regulators and doctors and patients about the addictive properties of the drug, and had to pay out $600 million in penalties, which of course, it's a small slap on the wrist compared to the billions of dollars that they were making in this. And there's a really great HBO documentary, if you ever wanted to see kind of more details on how that kind of unfolded, with Michael Keaton playing the main character there. And so all that to say, the second wave that I kind of mentioned earlier was really a part of some work to try and get people to not be able to crush up an oxycodone or OxyContin pill so that you could put it into a syringe and inject it. So they created an abuse deterrent formulation of it, so you couldn't really crush it up very well. And if you tried to add water to it, it kind of gunked up. You weren't able to really put it into a syringe to inject. And so at that point, that's when we really started to see people turning to heroin instead of oxycodone or OxyContin. And so, yeah, so we hit that kind of fourth wave there, or the second wave. That was around 2010. So in the meantime, a lot of folks were trying to figure out how we can actually help people who are already kind of addicted to oxycodone or heroin. And so there's a number of ways that we have developed strategies to address it. And I think really it's really helpful to think about a waterfall analogy when we talk about this. And I adapted this from Dr. Kamara Jones. She's a family physician who was also APHA president for a while. She has this cliff of good health paradigm that she talks about a lot in her work. And so I sort of adapted that with her permission and asked if I could include sort of the upstream kind of model to kind of combine with that. So when we think about preventing opioid overdoses or actually any kind of problem in public health, I think it really behooves us to think about ways we can attack it from different angles. And so I'd like to talk like first going upstream and then kind of midstream and then downstream. But let's start downstream because I think this is oftentimes where we see a lot of the efforts to prevent opioids is really like getting more naloxone out there. The Narcan, we should be able to have Narcan on every campus. We should have it in every government building. We should have it anywhere where somebody may have an overdose so that we can spray it up somebody's nose and reverse their overdose and bring them back and save them. But really, after they've kind of overdosed and they've fallen off this waterfall and they're kind of drowning at the bottom, it's really just a life preserver that's made out of paper. It's going to dissolve in about 30 minutes when that naloxone wears off, right? So it's not a great solution to stop people from falling off and overdosing, right? It's very downstream. So the goal is how do we move upstream and how do we put up some nets at the top of the waterfall to prevent people from falling off in the first place and overdosing. And so we're going to talk a lot today about medications for opioid use disorder, that is often known as buprenorphine, Suboxone, or methadone. These are medications that can help block those receptors so people aren't feeling the cravings to want to use, and also helps reduce the withdrawal symptoms that coming off of fentanyl. Things like harm reduction, like needle exchanges. We talk about overdose prevention sites where people can use on site, but also have connections to care and get connected in the pathway to recovery. Doing fentanyl strip testing so people can test their own drug supply and figure out if there's fentanyl in there or not so that they can make an informed choice whether or not they want to use it. So those are kind of midstream approaches, but really we got to move like farther upstream, right? We need to put up some fences along the river here so people aren't falling in that river of addiction in the first place. That's primary prevention. And that really is getting to things like helping get drugs off the street, helping people with healthy coping skills, addressing early childhood traumas, reducing stigma, really trying to help prevent people from using or relying on drug use as a crutch and as a coping mechanism. So that's very primary prevention. So we're going to talk some about those. So we're going to talk all three levels today, but I wanted to kind of frame it up for you initially. Going into the test strips a little bit, this is kind of one of those harm reduction models. This is a kit that we give out at the health department to people so that they can put a little bit of their drugs in here, whatever they're going to use, put a little sterile water, and then put a strip in there. And the strips kind of look like almost like a COVID test or a pregnancy test. And tells you kind of step-by-step how to do it. However, we always have to warn people that the test is the opposite of COVID tests and pregnancy tests, so that if it lights up, that's negative. If it doesn't have then there's fentanyl in there. Now, one of the problems with the pressed fentanyl pills that we see on the streets a lot they mimic oxycodone. They're blue pills with a little M on one side and a 30 on the other side. They're illegally manufactured and they have fentanyl in them, but it's hard to know how much fentanyl is in the illegal drug supply. Sometimes there's a little bit, sometimes there's a lot, sometimes there's none at all. It's kind of Russian roulette, when people are buying fentanyl off the street or any kind of pills that look like something else to know exactly what's in there. So we'd like to help people and empower people to be able to test to know themselves. Yes.
Add-on, I teach undergraduates and we show them two strips, the first strip is very small. So we say that this letting lines that we're not supposed to use.
Yes. Thank you. Yeah. Yeah, because you want to make sure that it's actually a valid strip, right? So if it's faulty and not working, you should disregard it and maybe try again. Yeah, that's a very good point. Thank you so much. And then, we're also working to make sure people, the harm reduction messaging of start low, go slow, people are going to be using don't use alone. Oftentimes, if we encourage people to call a helpline or a hotline or a warm line to say, hey, I'm going to be using, if you don't hear from me, check in. This is the kind of thing we're doing, especially in supportive housing, where people are not getting drug tested to stay in housing. It's maybe called wet housing, or sort of housing where people can still use, but we have staff around to ensure that people are using safely and not dying alone. And then I also like to give credit to one of my former colleagues, Steve Hardenberg. He always used to talk about this three-legged stool of recovery. And I like this because it really talks about sort of the human side of things. So when we talk about somebody going into recovery, it's really most successful when you can have all three of these legs standing. And that's really counseling or group visits or NA meetings, access to medication for opioid use disorder like buprenorphine or methadone, and then also some sort of friends or family support, right? And if you're missing one of those legs, you're likely going to topple over and not be successful in your recovery. So it's really, we try to put lots of arms around people to try and make sure that people are successful in their recovery journey. I want to talk a little bit about sort of some of the definitions of drug dependence, drug withdrawal, drug addiction. Oftentimes, dependence is marked by these kind of withdrawals. When you stop using, you're going to have symptoms, especially when we talk about opioids. You're going to have shakiness, clamminess, irritability, sweats, nausea, vomiting, diarrhea. These are oftentimes when your opioid receptors in your brain and your body don't have any opioids on them. They get quite angry and make you feel quite sick. And then addiction is really kind of just marked by this. It's really the behaviors that are really part of spending a lot of time trying to procure drugs and compulsive use despite harm, as well as cravings. And then the DSM-5 criteria are listed here, and this is really what we use to try to diagnose somebody with a substance use disorder based on these criteria. Compared to alcohol and tobacco, obviously opioids have a huge burden, and not only in deaths, but the amount spent each year. And we know that many people in custody, adults in custody, have been struggling with a drug addiction, but there's still a large gap in people who are actually receiving drug treatment in jails and prisons. So you can see maybe about half of adults in custody meet criteria for substance use disorder, but only about 15% are actually receiving treatment. So either we're not doing a good enough job screening people when they come into jails or prisons, or we don't have those medications or recovery options for people while they're there. And unfortunately, what that means is that many people who leave, well, first of all, it means that some people who come into to jail or prison are forced to withdraw off of whatever drug they're using. And that's quite painful and probably violates their 8th Amendment right against cruel and unusual punishment. But also, if they don't get any treatment or linkage to treatment while they're in jail or prison, and then upon release, they go back out to use, they may actually have no tolerance built up anymore. And oftentimes we see very deadly first use because they use at levels that they were using prior to being incarcerated, and they overdose because they don't have that tolerance built up anymore. So a lot of work's been trying to do that. Working with employers, really try to ensure that if somebody does have either a positive drug screen, random drug screen, or somebody suspects somebody of using fentanyl or heroin or any other kind of opioid while in the workforce, that instead of firing people, it's really a better return on investment to get them into recovery, some sort of rehab program. In fact, return on investment is around $1,500 for every employee who is going through those the drug treatment, and it leads to less absenteeism and tardiness and production loss. Here's an example of some of those secondary sort of harm reduction that we were talking about, kind of midstream approaches here. Insight is an organization based up in Vancouver, Canada, in British Columbia. They have a site that has been around for about 15 years now, which is sometimes called a safe injection facility or an overdose prevention center, where people can come in and use the drugs that they want with safe, clean supplies. And then as they leave, people say, well, you always come back tomorrow. We have drug treatment programs. We can get you in plugged in with care if you want to. And it's really that kind of like open-minded, lots of options, non-judgmental way of approaching people that's really been very successful there. And they always have a doctor and a nurse on staff, and they've never had an overdose death within one of their facilities because they can always respond right away if somebody has an issue. And so they've actually, the first 5 years they were open had decreased the amount of hepatitis C and HIV incidents in their area in downtown Eastside Vancouver by half that next following 5 years. So tremendous work really trying to help people do things safely and then also link them to care. Similarly, in Baltimore City, at their health department, they had developed 2 mobile vans that basically go out every day in Baltimore City and provide needle exchange for people who can bring back, a used needle and get a clean new needle. But at the same time, they also offer HIV testing, hepatitis C testing, and they get people linked to care that way. Okay, so I wanted to go through briefly, like kind of the more downstream, and hopefully you all are familiar with naloxone, or you have some naloxone on you. I always recommend people carry it. I carry it with me everywhere I go, and I've had to use it many, many times, unfortunately, in the streets of Portland. But I carry it with me because I know how dangerous it can be to be in a situation where you see somebody who's down and they're not breathing, and you feel kind of helpless. I mean, what should I do? So having naloxone on you is always a good idea to keep it on you. If you don't have some, hopefully there's resources here at OSU that can help get you a supply. If not, there's, health departments are often giving these out, and we can make sure that you can get some. But the idea is that you want to check, and first of all is make sure is somebody having an overdose or not, or are they just sleeping, all right? Or are they in cardiac arrest? Right. So the first thing is just sort of like visual, do a visual scan on somebody. If you can see their chest rising and falling, they're breathing, they're probably fine. They're probably just sleeping. If you feel like you can't find breathing, verbally saying, hey buddy, how's it going? Hey, are you with me? Are you with me? If they're not responding verbally, you can move to sort of the physical touch. And oftentimes I'll try and just like shake a shoulder or just try to not be too much in their space. But if you're worried about somebody, it's worth trying to investigate very carefully, of course, because sometimes if somebody is just sleeping and you startle them, they may get upset. But if they're not responding, the next step is a painful stimuli. And usually I'll take my knuckle and rub it right on their sternum there to try and provide that painful stimuli to see if I can wake them up. If that's not working and their lips or their ears or their skin is looking pale, dusky, gray, blue, it means they may not be getting enough oxygen. Sometimes I'll check in their pupils and see if it's pinpoint pupils is also another sign that they may be under the influence of opioids. So in those situations, call 911 right away, put them on speakerphone, leave your phone right there and let them kind of talk you through what's going on and tell them where you are and that you need help immediately. So call, spray, taking your little 1 dose, spraying it right up the nose, and then staying with them to actually provide support until EMS arrives. And so what this often means is trying to provide rescue breathing. And has anybody done rescue breathing either like on a CPR dummy or in real life? Okay, so you're familiar with like what that takes. It can be a little scary because oftentimes, putting your mouth on the stranger's mouth is a little too much for most of us. So what we recommend is if you don't have access to one of these kind of bag valve masks, which can often be found wherever there's an AED, where you may have somebody in cardiac arrest. But what they have now are these little pocket masks that are about this size on a keychain. And it's basically a little face shield with a one-way valve so that you can lay it on somebody's face and just breathe directly into their mouth and provide some oxygen to them until help arrives. And sometimes that's enough. Sometimes that'll kind of get people revitalized and resuscitated. Sometimes it's not. And so you wait about 2 to 3 minutes after that naloxone. And if you have another naloxone, go ahead and give that one as well. And just keep breathing for people so they can get oxygen to their brain. So check, call, spray, stay. are these really 4 important points that we've been trying to teach people more in the community how to get successfully revitalize and resuscitate people. Any questions on that? Makes sense. Oh, yes.
Looking back at, am I also doing presenting the same way?
Really?
Who's day? They'll have
Right.
So, introducing.
Oh, sorry. Yes, that's a very important point. Thank you. When you're doing this check part, you want to check for a pulse first. I should have said that. Thank you. If they don't have a pulse, that's when you're starting CPR right away, right? You need to get their heart circulating. So you start doing compressions right away. Remember CAB, compressions, airway breathing. So the compressions, like that's the first part. Yeah, you want to start doing, every 30 compressions, 2 breaths. And so that 30 to 2 for adults is the proper, yes, sir.
Yeah, I was wondering about old-fashioned pressure resuscitation instead of mouth-to-mouth if you don't have a face mask, for example. Does that work?
Well, hard to say. I mean, it kind of depends on someone's habitus, right? Are you able to sort of like press on their belly to like get their lungs? But oftentimes it's the influx of oxygen in that's really the needed piece, because their brain has probably already been a few minutes without any oxygen and could cause some lasting brain damage. So what I've done in the past, and it's not something I recommend, is I'll sometimes put my hands over someone to give myself a little shield and then just kind of breathe in through that way when I didn't have a shield around. If you're not comfortable with that, that's okay. EMS will come, they'll put that bag valve mask on somebody and they'll start getting oxygen flowing quickly.
And the current CPR instruction says to not do any kind of breathing at all, just continue the compressions. Is that changing?
It used to be ABC, right? That was when I first learned CPRs, airway breathing, compressions. Now they've kind of put the C front. So it's compressions, airway breathing, CAB. And that's because after, looking at tens, hundreds of thousands of resuscitations, they recognize that getting the heart pumping is really the most important piece in this, is like getting the blood flow happening. And that's for cardiac arrest. That's when the heart stops. But in situations like this, breathing is really the most important piece. Yeah, even before we had naloxone, right? That's what we used, was just rescue breathing to keep people breathing until EMS could arrive and give someone an injection of naloxone before we had these kind of very convenient nasal sprays. Great. I had this video, and maybe what I'll do is I'll just have the link. You can watch it at some point on your own, because it's really a great kind of like dramatized version. Has anyone ever seen The Wire? HBO's The Wire. It was a show that came out in the kind of mid-2000s about the drug scene in Baltimore. And this is at an NA meeting, a Narcotics Anonymous meeting. There's a famous musician, Steve Earle. He plays Waylon, who gets up and kind of talks about how he's gone through so much trouble being addicted to heroin in his life, that he's done all sorts of things. And he feels like he's finally in a place where he can help others now. And I think that piece is really important, because oftentimes we find folks who really they're in recovery. Oftentimes recovery is fraught with, what we used to call relapses or returns of use. Sometimes, people are going to have that happen to them, and that's okay. We really want to try to support people so that they can be successful in their recovery. And what we find is that peer level interventions, peer recovery specialists, and people who have gone through this are really some of the best messengers to help people kind of stay in recovery. So really, really powerful scene there in Wire Season 1, Episode 7. I'll talk a little bit more about when I was talking about people coming out of jail, because I think that was like a very challenging time in our country, because so many folks who were returning to community from jail were also returning to use and overdosing. But Rhode Island was one of the first to implement an MOUD program in the jails. They started giving Suboxone or buprenorphine to people in jails, and then help connect them with care once they got released. And their overdose deaths dropped 12% that first year they were able to do that, which was really impressive and led to a lot more jails and prisons in the country implementing these MOUD programs within their jails to help connect people. Another great resource I'll tell you about is this book, Dreamland by Sam Quinones. he masterfully interweaves these different narratives from the drug traffickers coming up from Mexico and targeting specific cities that already had opioid problems with cheap heroin. And so he talks about how these guys would go to methadone clinics where people already known users, built-in clientele, and they'd stand out in front of the methadone clinics and hand out a little business card that would have a little phone number on it. They say, hey, if you want some cheap heroin, just call this number. So you'd call the number, and it would be a guy sitting in the hotel room who would text page his driver these elaborate coordinates about where to meet you. And then you'd say, meet me at that corner. And the guy would come, and he'd drive, and he would have these little bag of heroin in his cheeks like a chipmunk, and he would just carry them in like little balloons. And if he ever got caught or pulled over, he would just swallow them. But then he would just meet you, give you, sell you the heroin. And they had this intricate drug trafficking scheme going for years under the DEA's nose and unable to sort of crack down on it. But he tells these stories it's very impressive what happened, really taking advantage of some of the drug trafficking schemes. And you can kind of see often, so this is like kind of 07 to 13, really the Eastern Seaboard was really kind of like the first kind of heavily hit area, kind of this Midwest area as well, followed by sort of the Pacific area here. And that really just was, drug trafficking, up the major highways. We got I-5 that really kind of ran up here. And actually, we work with law enforcement a lot these days to try and understand these drug trafficking patterns that are happening now, because they'll seize drugs before they get to the Oregon border, oftentimes before they kind of get into Oregon or Idaho. And so they have a high intensity drug trafficking task force team that tells us about all the different kinds of seizures that are happening these days, which is really helpful to know in public health. So I want to talk about a few things that we're doing at Multnomah County, kind of based on all this history. Where are we now? So we released an overdose prevention and response plan this year that really kind of laid out some of these upstream, midstream, and downstream approaches. And we really wanted to make sure that we were doing so in a way that was involving the community, that was culturally specific and evidence-based, that had geographical equity in mind, and that was really driving community health data. What we were noticing is that some groups were disproportionately impacted, especially our African American, Native American, and Latinx communities had a disproportionate impact. Their overdose death rates were higher than anyone else's. And so we wanted to work with those communities to try and understand what's driving these factors and these disparities. And so we launched or are continuing or expanding multiple programs on like the primary prevention, harm reduction, treatment, and recovery programs with community partners. And you can read this plan. This is the QR code if you're interested. That kind of lays out kind of our approach to this. And around the same time we released it, the governor, the mayor of Portland, and our county commissioner chair all declared a state of emergency around fentanyl. It was a 90-day emergency, started in February through April. And so it really allowed us to start getting everybody in the same room, community groups, governmental organizations, and really start having these conversations about what we can do to get on the same page here and stop being so siloed in our different approaches. We launched some pretty beautiful campaigns, communications campaigns. We would put up billboards in Multnomah County, pointing people to #recovery_is_possible, making sure people could get really quickly connected to drug treatment resources in the community as a way of doing primary and secondary prevention. And then we just launched this Expect Fentanyl campaign, which is a way for us to do youth-focused communication, specifically for youth who are really struggling with drug use. And as we're starting to see more and more youth be affected by these drug overdoses and deaths. So we put up big billboards near a lot of the high schools in Multnomah County and Portland, talking about how dangerous it is, but you may not be able to tell whether one pill that your friend gives you has fentanyl in it or not. And making sure that the kids had the access to nasal Narcan, Naloxone within their school-based health centers and in the community at large, and people knew how to use it. Yeah.
Are the fentanyl test strips also available in those school-based health centers?
That's a good question. I don't think so. I think those are available in our harm reduction clinics. But I think there's some students who are interested in bringing the fentanyl test strips to the clinic, to their schools. So I think there's some efforts at that. I'm not sure exactly where it is at the moment, but it's a great thought that kids students be able to test their own if they are using.
Quickly on the questions, if you could either speak up or can you repeat them?
Oh, yes. Yes, I'm sorry. Yes. The question was, our students are requesting fentanyl test strips. And the answer is I don't quite know, but I think it's a great opportunity for students to actually do more in empowering people to be able to know what's in their drug supply. Yes, another question.
Are you seeing kids as being addicted, or are these like one-offs kids are having?
Great question. Yeah, she asked it, are the kids addicted, or are these one-off events? I would say both. Sometimes what we'll see is that somebody who is not a user and uses for the first time uses something that has quite a bit of fentanyl in it, is very heavy, and shuts down their respiratory system and causes them to expire. That happens especially around our teenagers. Unfortunately, we also have some infant-related deaths too, where infants are maybe getting into some paraphernalia or some foils left around by the uncle in the community, in the home, and the children are getting into a supply or even residue from a supply that's causing them to die. So those are very, very sad situations, and we're always trying to make sure that people, if they are using, to like keep it locked away. That and any other medications as well. So it happens on both sides. And then of course, there's the students who are struggling, for whatever reason. Obviously we have a lot of the driver of this has been sort of the diseases of despair, depression and suicide and drug use that have really kind of gripped our country over the last couple of decades. And as we're seeing students feel hopeless, they often turn to something that will make them feel better. And drugs, especially the fentanyl, will make you feel pretty good. But then, because it lasts only a short amount of time, it wears off pretty quick, and then you're feeling worse than you did when you started. And so you have to kind of get back on it regularly. I have one patient I was seeing for a while who was using 30 fentanyl pills a day, smoking, on foil, just kind of freebasing the smoke. And that was somebody that we really tried to work hard to kind of get them onto the drug treatment and on that three-legged stool that I mentioned. I'll tell you about another pretty fun program that we're actually really proud of. We launched back in February, paramedic buprenorphine administration. And so this is a pilot with the Portland Fire and Rescue, their chat team, which is a community health assess and treat. And these are oftentimes the first responders to 911 calls for an overdose in the field. And these are oftentimes a wide majority of folks are houseless, people experiencing houselessness, and they may have overdose while using on the sidewalk or in a park. And oftentimes the chat team goes out and they will give them naloxone, reverse them. And once you reverse an overdose, you're feeling pretty crummy. You're in instant withdrawal, right? You're having all those symptoms I was mentioning earlier, sweating and feeling pretty sick. And so then they offer them buprenorphine right away. And buprenorphine is a partial agonist of the opioid receptor. So it helps relieve those withdrawal symptoms, but it also helps kind of give people that stability and support so that they are not craving to want to go and reuse fentanyl again. Then what they do is they take them right to an outpatient program where they can start getting buprenorphine regularly. And we've worked with Central City Concern, where I used to work, that has a walk-in buprenorphine clinic. So people can walk right in without an appointment, be able to get access to prescription for buprenorphine right there at their pharmacy. And if they're unhoused, they take them right to one of the tiny home villages that we have set up in Portland area with these pods where people can get indoors and start to kind of piece things back together. Then they follow up with them every week. They're checking in. If they don't have a phone, they'll give them a phone, and they'll check in, see how you're doing. Are you still engaged with treatment? And are you do you need anything else? And so they've kind of put lots of arms around people. So in the last 8 months we've been running it, we've had about 23 patients so far that would be initiated on buprenorphine. Almost half those folks are staying engaged after a week, and they're avoiding transport to the emergency room. A lot of times people don't want to go to the emergency room after this life-threatening event because they've had bad experiences in emergency rooms, or maybe they have people who kind of think that their symptoms are not real, or they kind of, get stigmatized while they're in emergency room situations. So oftentimes we just provide that care sort of, in the field, and then connect people to care without having to go through an emergency room. Now, some people are in pretty severe withdrawal, and maybe they'll need a higher level of care. So 5 of those 23 actually did get transported to an emergency room. And you can see there's a QR code too, if you want to read about the protocol that we're using for that. Yeah.
People are not starting to, if they drop off,
Yeah, it's a great question. She asked if what if people are not engaged, and what kind of happens at that point. So what happens when somebody is kind of on death's doorstep, like almost about to die, and gets reversed. Oftentimes we want to just stay with them, and so sometimes an hour, half an hour, just trying to help kind of like talk people through the situation. Some people are up and they're gone, and they just want to leave and they don't want to engage, and that's okay too. We want to be accepting of people and just be able to provide those services that people need whenever they come, and give people lots of choices and options. Yeah, but sometimes we have people kind of with multiple repeat overdose events happening quite frequently, and oftentimes our EMS system, they've seen these people multiple times. They know how to approach them, and oftentimes it does take a little while to develop that therapeutic relationship over time, so that they start to develop some trust and rapport, and then maybe that next time they'll be willing to take buprenorphine or go get connected with care. Yeah. Yes, sir. Did you have a question as well? Oh, okay. Sorry, I thought I saw your hand up. Okay. So next one I want to talk about. So we're starting to use a new formulation of buprenorphine called extended release buprenorphine, which is a month-long injection. So this actually can get people buprenorphine, so they don't have to take buprenorphine every day. Oftentimes when people are like, I mentioned the person before who's on 30 fentanyl pills a day, all right, it's just wildly vacillating roller coaster all day long, right? Buprenorphine, if you take it 2, 3, 4 times a day, can help kind of ease that out a little bit. But the new formulation, which is extended release buprenorphine, also known as Sublocade or Brixadi, allows people to have a month-long support. So that's really what we're really hoping to get more into our primary care settings. We have 7 primary care clinics at Multnomah County, as well as 3 jails that we staff. Corrections health. I'll tell you a little bit about some efforts we're trying to do to just bring everybody to the table. We've been holding these fentanyl summits. We had one in March, and we just had one last month in October, where we're getting people from the community, government staff, community-based organizations, payers like Medicaid, as well as hospital systems, and people with lived and living experience who really understand what it's like to go through this, getting together, talking about this work, presenting the latest data, serving on panels and talking about the work that they're doing in community-based organizations to try and provide support for African Americans, Latinx, Chinese, and Native American populations, as well as come together and do some roundtable discussion about what are solutions that you see need to happen, what type of funding needs to happen, and where does it need to go to really start supporting people more in these efforts. Yeah.
I'll just talk about it. Maybe you're already doing it. Do you have those in like churches or religious centers? They could also just he asked about house. So like you would like they come and they get it and they take it to the school. Is there something like that? Those kind of centers?
Oh, okay, great. So you're asking about like faith-based centers and other community-based organizations. Yeah. So we really want to make sure that, there's options for Naloxone, Narcan, so people can have access to that as well. And for buprenorphine, it's a prescribed medicine, so you would really need a nurse practitioner or a physician associate or a physician to prescribe it. But we are working on some efforts to get mobile vans out into the community so that they can actually engage with people in the community, be able to prescribe those medications out there, and get people connected to care without having people having to come into a brick and mortar clinic or hospital to get access to the medicines. Yeah, so that's something we're working on right now as well. Another cool thing is we're getting some Naloxone vending machines, right? Low barrier, low cost, immediate access to a life-saving medicine. And so this is the one we're purchasing right now to put in our central library downtown in Portland. So that people can come in and push a button, get naloxone, watch a quick video on how to use it and how to save somebody's life. And this is another effort to try and improve that very downstream but very life-saving effort.
And then,
Yes, we already have a lot of naloxone in schools. Yeah, all of our 9 school-based centers in Multnomah County have free access to naloxone for any student who comes by. And they also can train people how to use it there. Yeah. So as we're wrapping up, I just wanted to kind of tell you, the mindset really is shifting. And I think this is really important that we don't just treat addiction as a moral failing. This is a disease that we can treat like any other disease, like diabetes. For folks who need insulin for their diabetes, people also need access to buprenorphine or methadone for their opioid addiction. So I really want to try and push on these policies that really help people, not punish people. And then I think this, trying to build these coalitions, these community efforts where we're getting everybody in the same room talking about how we can work together on these efforts is really paramount. There's been a lot of changes in the ability to prescribe lately. 2021, it used to be really hard to prescribe buprenorphine. Now it's much easier for providers to provide it. And I think it's really impinging on us to be good advocates and allies for people in our community who are suffering. So writing op-eds is one way to kind of get the word out there about ways that you feel like things should change. So I'll end here, and we'll happy to answer questions for the folks in the room or online. Anything that is coming to mind or you'd like to discuss further. And thank you so much for your time today. I think in the back first, yes. Yeah, in the red coat, yes.
I'm really interested in that data dashboard that you release and curious to know how that's impacted your prevention, like upstream, downstream efforts. Because it seems like I imagine it was a huge labor to get all those partners to come together to share data in that way. Right. So I want to know what kind of an impact or how you're utilizing that information.
Great. Yeah, it's a great question. He asked how the opioid overdose dashboard that we released back in February is having an impact on the work that we're doing to try and prevent overdoses on all 3 levels. And the answer is yes. We feel like based on the numbers that something is working, right? It's kind of hard to isolate exactly which part is working. But what we know from our community partners and the work that we're doing in our clinics in Multnomah County, our 9 primary care clinics, is that you have more people who are able to access things, and you see the repercussions of that access being that people are not having as many 911 calls, or as many overdose events. And so our efforts are trying to figure out where do we put the eggs, right? Because the funding is always limited, right? It's like, how do we distribute funding? Should we focus more downstream, more midstream, more upstream? My goal is always to push us more and more upstream, right? Because I feel like the power of prevention is that you can prevent people from having those downstream events, that's much less costly. So we feel that, moving upstream, doing more of that communications campaign, doing more of that primary prevention, getting more behavioral health providers out there to help diagnose and get people mental health is really an important piece of this, because oftentimes people with a dual diagnosis of a mental health disorder and a substance use disorder together can make people much more likely to have an overdose event and die. So more behavioral health is really important as well. Access to treatment, access to counselors, all of this is tremendously important. And so we feel that the numbers are going in the right direction. We're still trying to push on these different interventions that we're doing in the community based on that work, and really just working with our community partners to feel like what's actually feeling like it's actually helping, and what does the data tell us? So TBD.
Yeah, thank you.
Yeah. Yes.
First of all, I'd like to say that the hard to do, we remember the thing, not just with working, but in fact, so many people in fact don't. It's already one thing that you made it in that open program, the urban land, and what the way that we to actually and then we out to high school and whatnot. But in the slide, you mentioned that it would have been better if we encouraged brand rather than and invest on the treatment rather than hiring. So I wanted to ask, is there any program or place where you school students and then treat them while they're not and get them to get well?
That's a great question. She asked if we are screening students and being able to provide resources for students along that life trajectory there. Oftentimes they're self-referrals, right? Or maybe a friend says that, I'm worried about my friend, I think they're using, and I get some help from an adult to help approach the student about, maybe some dangerous use. We really kind of rely on peers and teachers and administrators in these high schools to help provide some eyes and ears, among the student body. But there's no way to really necessarily do a drug screen on every high school student. That's not really that'd be kind of invasive. So we really just kind of rely on students self-referring and just putting a lot of signage and messaging up in high schools, and especially around the student health centers, that these options are available. You don't have to suffer. You don't have to suffer alone. We're here to help you.
And is there a program like impulses and
well, it depends on the jobs, so a lot of safety-oriented jobs, let's say someone in construction, for example, or a truck driver, they oftentimes, their jobs are screening them upon entry and then random drug screenings thereafter to see, are they using? And what the big push has been recently is to say, don't fire those people if they get a positive drug screen. Help get them into treatment. Here are some options. Because if we can get somebody supported and returning to the workforce, that's a better pathway for them and for the employer, rather than firing somebody and then they downward spiral and they're just using or maybe overdosing and dying in that kind of pathway. So yeah, we find it's much more humane to actually help give people access to the treatment they need. Yes, sir.
And there's a big difference between addiction and a dependence.
Yes.
And the key thing is when you use an opiate or something, it causes a really overflow in dopamine stimulation. And that causes the cells, neurons that are receiving the dopamine, to defend themselves by destroying dopamine receptors. And they apparently do not come back, which means after the first use, the person is never going to feel as good as they did before that first use unless they're on drugs. So it seems that the important thing is to prevent that first use.
Yes.
And the first use comes, we talk about different groups having different proclivities towards using, and that's not a question of genetics or anything. It's a question of culture. So how do you go about changing it to prevent first use?
Yes, very important point. How do we prevent first use? So, gosh, I could go back to that waterfall slide because that's really the one where I listed a bunch of primary preventions of how do we prevent people from falling in that river and starting use in the first place, right? And it really is helping people with the support they need and the healthy coping skills, opportunities for exercise and sports and things that help people get that dopaminergic surge in a healthy way rather than an unhealthy way. And I think that really is just it's a societal question. It's a philosophical question. I don't have all the answers, but what we see is that if we can get to students young, elementary, middle school, high school, if we can help support them in ways, that they're struggling with all sorts of stressors these days, whether it's, the election this week, or if it's, students who are actually dealing with, seeing a murder or any of the adverse childhood events, ACEs, that happen to a child young, that put them on a pathway where they may not be able to engage as well socially or have trouble in school. How do we help support folks early? And that's very upstream social determinants of health, really kind of helping change society and the systematic changes that'll make it easier for kids to live healthier lives.
It's basically a change in culture.
Yes.
And right now, the commercial media are doing their best to not change the culture. How do you fight that?
Well, as a health officer at a county health department, I try to work with the media as much as I can. So I'm oftentimes the physician ambassador for the health department. So I'm on the news, talking to the TV cameras, trying to tell them, look, these are some programs that are actually working here. It's not all doom and gloom, news cycle, clickbait. it's actually, there are some pretty amazing things that are happening in our community right here. And we can support those and highlight those, through the media as well. So trying to tell the positive story, but I hear you, it's very challenging these days. Yeah.
I want to thank Dr. Bruno very much for his time.
Oh,
Thank you
yes,
so much.
of course. Oh,
Thank you on.
Well,
oh, yes. Yes, please.
Sure, absolutely.
when how are you beginning, but it is so long, then what has the last into almost taken. You are the gas is one, and that was the one.
Ah, yes. Well, there's many potential repercussions. I can talk about, public health funding is always on a precipice anyway in any administration. We feel like it may be particularly challenging now. But what we will try and do is keep working on trying to buffer the work that we're doing here in Oregon by ensuring these kind of robust infrastructures and connections with people. It may mean turning to more philanthropic giving for grants rather than governmental CDC or NIH grant funding. So we just have to navigate that process and figure out how we can keep doing this important work, even though funding streams may be in jeopardy. But great question. Thank you. Yeah. Thank you, everybody. And everybody wants